Hello, everyone. Today, we are here with Dr. McCollom, and we will be talking about pain in terms of in the event of the Pain Awareness Month. Thank you for joining us today.
No, it's a truly an honor to be able to share a little bit about my heart. I'm always assisting and coming alongside patients and their families suffering from cancer-related pain, but I don't see it talked about as much. So I'm really glad you're focusing on that for a topic this month.
Yeah, definitely. So to begin, could you share a little bit about yourself and what inspired you to pursue like both oncology and palliative medicine? And what has your journey been like in bridging these fields together?
Oh, that's a great question. So, my name is Dr. Joseph McCollom. I am dual trained both as a palliative care specialist and also as a medical oncology specialist. And I also dual practice. So, I get to do half of my practice as a GI subspecialized medical oncologist, and then the other as a palliative, supportive, and survivorship oncologist, all here in an outpatient practice. And I've always really enjoyed the intersection between care against a disease and care for a patient. And I feel like patients who are supported in their journeys tend to do the best of all patients. And so I had some incredible mentors in medical school who inspired me with their own careers and practice and have seen the field really catapult and grow over the last decade. And now I'm just honored to be a part of the community on a national level.
Yeah, no, it's definitely something unique and definitely something to aspire, even, as fellows, as you go through, because it's never too late, to think about even PalMed or palliative medicine to do add on a year or even like later on, right? Like some people do choose on to go back and do additional fellowship because I think it's a great asset to have for sure. And your patients must be very, very lucky to have you.
Lot of what we do in palliative medicine is communication. And so I think
Hmm.
there is great value in palliative care fellowship because you get to focus on that art of the conversation for a year. And now they're even creating innovative practices where you may only train 2 or 3 years and be qualified to sit for your palliative medicine and your oncology board. So there's a lot of opportunities for any interested trainees or students who are thinking about this career.
Yeah, no, that's definitely exciting. So, as you said, pain is like one of the most common and feared symptoms in cancer care, right? From your perspective, like what are the biggest misconceptions patients and family have about like cancer-related pain?
That's a perfect question, Dr. Hundal. And honestly, I think one of the most important aspects of cancer-related pain kind of reflects what Dame Cicely Saunders had described way back in the 1960s, this kind of concept of total pain, that pain itself is not just a physical phenomena caused by a tumor kind of turning a light switch on. It also integrates other aspects of a patient's experience, including their emotional pain, social
Hmm.
pain, and spiritual pain. And so to truly address a patient's pain experience, we really have to address all the facets and aspects of that experience. So you really need a holistic approach with a multidisciplinary team to tackle every part for that patient.
Yeah, and it's like I loved how you kind of labeled different pains. It's not just the symptom pain, the bone pain, but even like the emotional pain and the other things that come with it. So, despite advances in medications and supportive care, many patients still experience like the undertreated pain, right? So, what do you see as the main barriers, whether it be medical, cultural, systemic, or to achieving like adequate symptom control, not just like the specific pain control, but just in general, like overall symptom care?
No, that's a great question. I think you've identified, right, a lot, so many different aspects and facets of barriers that prevent patients from achieving adequate pain control. I think one, surrounds the major medication that we utilize for pain management, and that is opioids. I think opioids have had a significant stigma associated with them, despite being the
Mhm.
cornerstone of cancer pain management. And I think a lot of that, was really magnified around the late, 2010
Mhm.
decade because of the opioid epidemic. And I think there was a lot of individuals who and even healthcare providers who responded to the opioid epidemic with a complete 180 reversal, and
Mhm.
really trying to look at opioids sometimes as a last ditch effort. And so sometimes it's the patients themselves that are
Mhm.
hesitant to consider therapy. Other times it's the caregivers. They're not
Mhm.
sure if they want their loved one on a medication like that. Um, and sometimes it's the medical providers themselves. They may not be as
Mhm.
experienced as they once were, or have concerns about developing a trusting relationship with their patients. And so I think, combine that with the fact that the amount of individuals who practice specialized palliative care, as I do, is very small compared to the amount of patients with cancer-related pain. And you're really dealing with a system-wide access issue.
Mhm.
A lot of patients with cancer-related pain, not a lot of medical providers who are confident and qualified to treat it.
Mhm.
And as a result, as oncologists, which we both are oftentimes now left with a patient who's suffering, and how do we create or hone our primary palliative care skills as oncologists to be able to support that patient and make sure that they're not suffering despite very real cancer-related pain. And so I think there's a lot of work to do. There's a lot that has
Mhm.
been done, but there's still a long road left to walk in terms of mitigating stigma, ensuring patients remain safe,
Mhm.
but getting effective pain strategies. And being able to increase education and comfort levels, both on the patient level and the provider level, when it comes to proper opioid prescribing.
Yeah, definitely. There's a very fine balance and it's an art to it, right? So not everybody, as you said, is able to do it perfectly. All right. So how does like early integration of palliative care into oncology treatment improve like pain management? And from your practice and experience, how do you think has that impacted the quality of life for your patients or even like caregivers at that point?
No, that's an excellent perspective. I think that, one of my favorite studies that I looked at, Dr. Ali Hader from MD Anderson had presented an observational study back in 2019 that
Mm-hmm.
showed that when specialized palliative care got involved with the patient's care, they were able to reduce their pain scores without increasing their oral morphine equivalent dose of opioids. How is that possible?
Mm-hmm.
You didn't actually give them more pain medicine, but their pain experience was different, was better. And I think it goes back to that idea of total pain. I think we as the palliative care practitioner, or even we as oncologists, are the intervention for our patients.
Mm-hmm.
And there's something to be said about therapeutic presence. And I think in palliative care, we try to protect time focusing in on the patient. A lot of patients still don't understand what palliative care is and what it does. A lot of folks who know the word palliative care equate it with end of life care. And they're worried as soon as they see an early integrated palliative care professional that their oncologist is trying to communicate something negative about their prognosis to them. And so it's really important when I walk in the room as a palliative care specialist that I qualify what I do for patients. And the way that I describe it to people is, imagine if you saw someone standing out in the pouring rain and you walked out to that person and you just took off your coat and you wrapped it around that person. The word palliate comes from the Latin palliare, which means to cover or to cloak. And so just getting that experience of being covered, being cloaked. Now, did you impact the rain from falling from the sky by doing that? Did you stop that? Well, no. And that's what we try to do as medical oncologists,
Mm-hmm.
right? Like we try to control the weather.
Yeah.
And sometimes we're successful for a season. Sometimes we're not successful and our medications fail our patients. But Regardless, I think as a medical oncologist, my focus ultimately is disease and how do I manage that disease with medical
Mhm.
therapies and approaches. My focus as a palliative oncologist is on the patient and how do I help them and help their loved ones, the community in which they live, because nobody goes through cancer alone. How do I
Mhm.
help them support each other in that process? And I think Dr. Jennifer Temmel's landmark New England Journal of Medicine article really opened the doors for this in 2010. She was looking at early palliative care integration for patients with non-small cell lung cancer. And again, this was in
Mhm.
an era before
Mhm.
immunotherapy and some of the targeted therapies we have today. And her medical oncologist colleague said, okay, we know you're going to improve quality of life. We know you're going to
Mhm.
reduce pain, but we want you to track overall survival as well, because what we think, our hypothesis is that while those things increase, overall survival is going to decrease. And what she found, in fact, was quite remarkable that overall survival for those patients with early integration of palliative care and non-small cell lung cancer increased significantly. So
Mhm.
much so that Atul Gawande, and I'm paraphrasing in his book Being Mortal, had said, if palliative care was a drug, the FDA would approve it based on the overall
Yeah.
survival improvement of that study. And since then, I think we've seen multiple studies that show that early integration of palliative care in advanced cancers improves pain, improves quality of life. And it's not just for patients, it's also for caregivers, that it
Mhm.
helps reduce their burden and it reduces healthcare costs ultimately. You get less expensive care that's not going to necessarily improve your quantity or quality of life, and more goal concordant care that fits things best. And I think ultimately, if we can generate more referrals earlier on in the process with patients, it gives us time to establish rapport, make those connections, and really impact them when they do progress for those advanced incurable patients towards the end of their life. Dr. Justin Sanders updated the 2024 ASCO guidelines for palliative care for patients with cancer. And he was really looking at an 8-week window for recommendation. So that
Mhm.
if you are a newly diagnosed patient with advanced or incurable cancer, within 8 weeks, you really should be
Yeah.
establishing with a palliative care specialist. And the impact, I think, can be very dramatic.
Mm-hmm. No, definitely very great points. And I feel like establishing that, even as you said, like that 8 week window with advanced cancer, right? That doesn't mean that we're thinking like, the patient doesn't have long to live. Like, and actually it's the opposite, right? Even like advanced metastatic disease now, we have such great therapeutic tools in our toolbox which we can apply, and then our patients do very well for years and years. But we also want to focus on their quality of life. So I think that's a really important point that you brought up, and is really important to consider for for us, but also for patients and caregivers. And then along the lines with like there are pharmacological options that we have, but when managing cancer related pain, what is your approach to integrating like non-pharmacological or supportive strategies such as like physical therapy, integrative medicine, mindfulness, alongside with traditional treatments?
Yeah, I think that's a beautiful concept that you brought up because it really goes back into that idea of total pain. Pharmaceutical medications could block or modify the pain signal in your nervous system. But a lot of the experience that we're having when we have a cancer related pain is not just the signal from a nerve going from your tumor to your brain, it's an experiential trauma. That goes back to all of your earliest memories of pain and
Mhm.
trauma, and experiences with illness, all the way up to your current time. And so, I think one of the greatest impacts in our personal practice has been the integration of nurse navigators and master's trained social workers, having that companionship, that guide to alleviate some of the challenges that come from the uncertainty of cancer, having experts at your side, being able to process the emotional warhead that cancer
Mhm.
has detonated in your life. It really has an impact on patients' pain. Their
Mhm.
focus is less inward on what's wrong and what's broken for them, and its focus is more outward on what is their
Mhm.
experience able to still keep in close connection in their lives. And so many of our patients also have undergone dramatic physical changes in their
Mm,
bodies as a result of the cancer, which then can cause changes in their experiences of pain. For example, many of my patients with pancreas adenocarcinoma, an aggressive cancer of the GI tract, can have a condition called cancer cachexia, where the cancer
mhm,
itself is causing a pro-inflammation state that causes them to lose muscles, and it's very difficult to regain them. And so some of them can't be physically active because of the disability from their tumors. Some of them can't be as active because of the disability of their treatments. And many of them, even those who may have had a high fitness, high activity background, their bodies have changed. They're older adults, many of my
mhm,
patients are, and they're afraid that if they exercise excessively, they may injure themselves or get themselves into a worse situation. So, having a partnership with a physical therapy team and rehabilitation team can be really valuable at creating these customized programs that help patients rebuild themselves slowly over time. And I think it's so valuable as an augment to pain control. There's so many different complementary and integrative modalities that can modify the pain signal, everything from mindfulness to
mhm.
yoga and Tai Chi. But so little patients have access to these skilled
Yeah.
individuals in the community, and even less have clinicians who are guiding them towards those practices. I think there's this idea that these therapies are what we call alternative, that you have to either choose
Mhm.
all medical oncology treatments, chemotherapy, radiation, surgery, targeted therapies, immunotherapies, or you choose alternative medicines like Tai Chi, yoga, mindfulness, herbal preparations. You can't do them integrated. And I think I love the idea of integrating oncology. The Society of Integrative Oncology actually partners with some of the major medical oncology societies like the American Society of Clinical Oncology, ASCO, to create joint guidelines that have high
Right.
quality evidence that supports those modalities and avoids things that are probably going to be very little benefit for patients, but could be significant cost to them. So it kind of is a great way of separating the wheat from the chaff. You know, what's really valuable in the complementary and integrative space versus what may not be as impactful for whatever symptom that patient is going through, including pain.
Yeah, I totally agree. It should be like hand in hand rather than like noting it as like alternative therapy because that's kind of like a misnomer. And I feel like it's also stigma, right? When patients like
Mhm.
come, I've heard it like over and over, like, sometimes like, oh yeah, the patient chose to do alternative therapy, but that doesn't mean that they forego the other traditional, pharmacological therapy. They're just doing it hand in hand for their symptoms. And actually, I always get very excited when I see studies that also looked at the biological mechanism behind the non-pharmacological treatment, because that then just shows us that by whether being engaging in exercise or mindfulness exercises, there is a correlation of decrease in whether it be inflammatory markers or the tumor biology. Although, these studies are usually just observational or not randomized, but I feel like hopefully down the road we see more and more of these studies that show that these actually complement each other and it's not like one over another.
Absolutely.
Yeah. All right. So I guess our last question today will be what innovations or approaches, whether in medications or integrative therapies or digital health, are you most excited about for the future of the pain management in oncology?
Well, I think we both share a mutual passion for integrated technology in terms of supportive care for patients with cancer. And one of the things that we see increasingly emphasized, both in research and in practice, has been this concept of patient-reported outcomes. And
Mm-hmm.
now we have digital tools that create an electronic patient-reported outcome, or ePro,
Mhm.
And it really is allowing us to be able to get that real-time feedback for patients about what symptoms they're experiencing on individual therapies that allows us to turn the dials up and down on treatment or up and down on support for patients.
Mhm.
Now we're seeing an increase of artificial intelligence,
Yes.
AI tools in this space. And so our institute is looking at some programs that are utilizing large language models
Mhm.
that can interact with patients undergoing chemotherapy. So you are a patient with breast cancer, you're undergoing ACNT, you're having some toxicity, maybe it's some pain, and you reach out to this large language model. It's 2 in the morning. You don't
Yeah.
want to have to call the on-call line and wake your doctor up, but it's really significant for you. So you talk with this large language
Mhm.
model, and it's able to have evidence-based review of systems questions that are trained by the best of supportive care guidelines that we have
Mhm.
accessible to us. And it's able to ask those questions and really explore the patient's experience of pain. What's the severity? What's the location? What are the associated symptoms?
Mhm.
And it's able to stratify based on the patient's responses to them and either provide immediate feedback, guidance. This is okay. This is a mild inflammatory pain that you are experiencing because of your GCSF that you got. Here,
Mhm.
take some over the counter Claritin, take some over the counter ibuprofen, and you can call your doctor in the
Yep.
morning, right? Or it can escalate those to a triage nurse and realize,
Mhm.
okay, this is a serious pain. We're going to reach out to our nursing team and they're going to give you a call because we are concerned this could be a serious pain. This is a burst fracture in your C4. And this is actually something that could potentially cause permanent paralysis. And then that nurse calls, gets more history, is able to get that patient directly to an emergency department, which otherwise they may have delayed. So I think we're
Yeah.
going to see more innovative tools like this, digital tools that will be revolutionary in
Mhm.
triaging patients, especially in areas where I practice in a largely rural community setting.
Mhm.
With limited resources, it'll provide helpful guidance to patients and critical interventions to persons whose pain is actually a signal for a more serious cancer related complication.
Yeah, definitely. I think those are great points, and it's definitely very, very exciting. And I feel like there are always like a lot of concerns around AI and technology, but I think like with working, collaborating with companies and them like showing transparency and how they're training their models are like really key. And I feel like if they're well trained and as you mentioned, like if they are basing it on expert opinions, then it's going to be just as clinical trials we see how drugs work. It's the same vetting is needed for these AI tools as well.
Absolutely.
Awesome. Thank you so much for your time today. Before we end, do you have any last message to give?
No, I just would encourage anyone who's listening, if you haven't had much of a clinical experience with a palliative care specialist and you are an oncology professional or a patient, please reach out. Look and see what your local resources might be. There's so much value in cancer related pain that an integrated palliative care specialist can offer. If you are an oncologist and you really want to increase your skills on cancer pain management, reach out to your local palliative care clinicians. There's a lot that we can teach and learn from one another when it comes to the support for cancer patients, specifically in cancer related pain. And there's so many resources out there that can be of value to you. Um, but hopefully, this has opened some doors for you to consider what palliative care is and could do. And hopefully, we'll have ongoing conversations more in the months and years to come as we see new innovations take place in supportive care for patients with cancer pain.
Yes, definitely. Thank you so much.